And thank you for the invitation to join you this evening. And I congratulate you on what has been and is an excellent lecture series, and well done on that. It's a great idea. And I'm a little bit annoyed I didn't think of it myself 10 months ago. So I'm just going to talk to you about prosthetic joint infection, and I'm sure there's going to be some overlap between both your talk and mine. So I'm coming from Sligo University Hospital, which is the northwest of Ireland. It's a mostly rural community, but we have some excellent natural scenery, and this is Ben Bulben Mountain in the background. It's one of our most well-known mountains, and that's Classybone Castle. We have the Lake Isle of Innisfree, which was the name of a poem by William Butler Yeats, who is our local Nobel Prize winner for literature in 1923. And in a lot of his writings, he talks about Sligo and includes a lot about the natural landscape. That's Ben Bulben again. We also have the largest collection of megalithic tombs in Europe, and they date about 6,000 years old. So I think they may predate the pyramids. I'm not 100% sure on that. And we're also the surfing capital of Ireland, and Dr. Ibrahim Kamar, who's a good colleague of ours, is really taken to that with his usual zest. So he's getting used to the surfboard. So just talking about hip and knee replacements, there's been a 50% increase in total hips and a tripling in knees between 1990 and 2002. There's a projected 174% increase in total hips and almost a 700% increase in total knees by 2030. And this is all as per Kurtz's paper in 2005 and 2012. The rate of PGIs in hips and knees is roughly about 2 to 2.4%. And that cost is expected to exceed 1.62 billion in the US by 2020, with an indirect cost of over 10 billion. So the stakes are quite high financially. The rate for both hips and knees is, in most of the research is coming in around 2%. In the Nordic register, they found cumulative 5-year revision rate for infection rising from 0.46% between 95 to 99 to 0.7 to 2005, 2009. So almost a doubling of numbers. And in England and Wales, it's also increasing. Interestingly, the rate for shoulder seems to be lower, elbow seems to be quite high, probably due to soft tissue coverage. So the mortality is estimated to be between 1 and 2.7% and can even be higher and up to 8% in elderly patients. The cost, as I mentioned, is pretty significant. And the cost per year to treat is 3,500 to 4,000. Total joint infections is between 150 to 200 million per year. The hospital cost per patient for revision due to infection is almost 5 times that of a primary total hip. And the incidence of prosthetic joint infection is highest during the first year after implementation and declines thereafter. There are, like lots of things, patient factors, local factors, and surgical factors, but it's the usual things like age, BMI, smoking, diabetes, steroids, malignancy, and rheumatoid are the most common patient factors. Things like previous trauma, previous arthroplasty, fractures, and perioperative wound complications are the main local factors. And then the surgical factors, really the big one there is operative time and hemostasis and antibiotic prophylaxis. Looking at the causes, the main cause, gram-positive cocci, coag-negative staph aureus, and streptococcus. They're over 65% of cases, with fungi being less than 1% usually. Charnley did say that joint sepsis would be the major hurdle in our way in the future, and how right he was. And it's not so much that we're just hitting the tip of the iceberg now, but it's the shark-infested waters that we're also having to deal with. So this is a big problem that's becoming more and more apparent with each passing year. And with the increase in the amount of work we're doing, we can expect this to be a huge problem for us in the next 10 to 20 years. And the consequences of an infected hip or knee replacement are potentially devastating. They can result in death, they can result in amputation, and they have a significant impact on patients' quality of life. This is a very good paper from Kurtz and Parvizi. Again, it looks at the pattern of infected hips and knees from 1990 up, and we can see it's just going one way. And it's important to talk about how it impacts on mortality. When it's adjusted for confounders, prosthetic joint infection is associated with a 4 times increase in the odds of 1-year mortality compared to an aseptic revision. And that's a very interesting paper to read from 2013. If you look at PGI and compare it to a lot of the most common cancers, we can see that the 5-year survival for PGI is actually worse than a host of infections such as testicular, Hodgkin's, melanoma, and breast. So that's quite a significant graph, and it's important to sit back and just take that in. So really what we're dealing with is something worse than some cancers. When you look at non-cancers, we can see that actually it has a worse outcome in terms of mortality of revision than some cardiac cases have. Like everything, we have classification systems for infection, and McPherson's and the Coventry are the two main ones. We grade them into early, grade 2 or grade 3, which is late, and then host factors A, B, and C, depending on the compromising factors. Then the Coventry classification, again, type 1 to 4, I'm sure you all know that. The MSIS has a definition, pretty much breaking it down into major and minor criteria. And this has been modified a few times. The International Consensus on Prosthetic Joint Infection have done a lot of good work over the last few years in trying to classify it and trying to streamline ways of identifying, diagnosing, and dealing with it. So the last meeting was in 2018, and they they formulated their major and their minor criteria. And really, it comes down to having 2 positive cultures of the same organism, a sinus tract with evidence of communication, and then the minor criteria, we're looking at CRP or D-dimers, ESR, synovial white cells, alpha defensin, synovial PMN, synovial CRP, and then various other things. We look at the sensitivity and specificity of the different guidelines. We can see that the new guidelines have a sensitivity of approaching 98% with a specificity of 99.5%. So it's pretty accurate. So the real problem with PGI is the formation of a biofilm. It happens in the first 30 days, and you get this initial attachment of bacterial cells. They aggregate and accumulate in multiple cell layers. You get this elaboration of the matrix and biofilm maturation, and then you get detachment of cells from the biofilm into a planktonic state, and they form new biofilms elsewhere. And once the biofilm forms, it's very, very difficult to eradicate it. So Costerton talked about this micro niche, this complex microbial community that has a primitive homeostasis, a primitive circulatory system, and metabolic cooperativity. So once it forms, it pretty much is self-sufficient, and it's very difficult to get to it and to eradicate it. It's all about nutrient depletion. It creates this zone, so the inner zones of the biofilm are protected by the outer zones, and by the time the antibiotics can get to the inner zones, it's given it plenty of time to form a stress response, and it's protective of the organism. So how do we diagnose a PGI? As with everything else, it's important to take an appropriate history and examination. You're really interested in the duration of the symptoms, the time since the index surgery, the type of implant used, what the inflammatory markers are, in particular the CRP and the ESR, blood cultures, if febrile, the x-rays, what do they look like? Is there any evidence of loosening? And then you want to aspirate the joint and send everything off for culture. So ESR and CRP alone are actually pretty good in terms of helping to diagnose an infection. They have a combined sensitivity of about 97%. And that's a good paper again by Parvizi, who's very much the main player in this whole thing. Also, you're looking at synovial fluid, white cell count, and there are different numbers for both hips and for knees, and at what stage they are post-operatively. Also, the simple urine test, the leukocyte esterase test, pretty specific at 80% sensitivity to 100% specificity. And again, synovial fluid alpha defensin is pretty good with a sensitivity of 97 and a specificity of 100%. A lot of good papers coming out from the States really looking at alpha defensin, and particularly from the Rothman Institute. And they seem to, they're all approaching 97, 98% specificity and sensitivity. But having used it myself a few times, and I know a lot of my colleagues here in Ireland have used alpha defensin, wouldn't really be getting it, wouldn't agree with the sensitivity level that it's been advertised with. It's less reliable than I think the papers tend to say. But again, plenty of research looking at its accuracy. Again, 98, 97%. So continuing with diagnosis, periprosthetic tissue is more accurate than synovial fluid. So if you can get some of that, send it off for histology and frozen section. The one caveat is that really you need a properly trained musculoskeletal pathologist, and they're not that easy to come by. And something else described, which we don't use here, it's sonication of the prosthesis. using low intensity ultrasound can result in disintegration of the biofilm, and you send off that for culture, and that has been shown to be more sensitive than synovial fluid, and is not affected by previous antibiotic use. So that's also something to look at. Again, imaging is plain film is not really reliable, but you have various bone scans. Technetium 99M has a sensitivity of 50 to 70%, and indium 111 has a sensitivity approaching 90%. And PET scans, 98%. So once you've diagnosed it, then what are you going to do? And there are various options, and a lot of it depends on what kind of patient you're dealing with and in what kind of center you're practicing in. So the debridement and conventional antibiosis, it removes most of the bacterial load. It may or may not disrupt the biofilms, and you may not remove the microscopical biofilm remnants. And in that case, you won't fully eradicate the infection, and you leave minimum biofilm eradicating concentration. It's important to know this term, the MBEC, and it's the minimum biofilm eradication concentration of an antibiotic. That's a measure of the in vitro antibiotic susceptibility of biofilm producing infective organisms. There isn't any clinical MBEC. It's a lab measure, but there is research ongoing to establish a clinically validated. DARE is debridement and implant retention. It's really only suitable within the first 30 days post-operation, and that's really because you're trying to get in before the biofilm has matured and formed fully. The group in Oxford are very DARE procedures, and describe very good results with this. Again, it's only applicable and useful in a very specific cohort of patients. You really need to know the type of organism you're dealing with, and it really has to be in the first 30 days. There is a high risk of failure in eradicating the infection, and that's been well described in patients with coexisting diseases such as rheumatoid, diabetes, and renal failure, all do worse. With a failed initial DARE, you can have a 70% success after a subsequent 2-stage. And to be thinking of a DARE, you really need to know the organism you're dealing with. It has to be previously asymptomatic and have benign radiographs. You have to meticulously debride everything and all the soft tissues. You check your components, remove the modular parts, you obviously pulse lavage with chlorhexidine, meticulous closure, and get plastic surgical input. This is results from the Oxford group. Again, they're describing a 5-year implant survival of 85 to 92% and 10 years at 77%. Again, more from the Oxford, and better results within 6 weeks. Another study showing 10-year survival of 86%. Exchanging the modular components is important for better survival. And again, early is best with exchange of the modular components. All of this data is from Oxford, and again, I think it's a centre that do a lot of these. I think if you're in a smaller unit like we are, it probably is less appropriate to be doing them. But interestingly, the type of organism didn't affect the 10-year survival. But with DARE, I think the things to remember are you change the modular components. The organisms can affect the success rate, but not whether DARE should be formed or not. Better results the sooner you do it. Can leave well-fixed implants, including the cement, and you can exchange either components and convert it to a 1-stage or a 2-stage later if you need it. Comorbidities do not affect the outcome, although some research has contradicted that. So again, principles for biofilm elimination: you have to localize it, you have to reduce it by mechanical means, you disrupt it, mechanically disrupting their environment. You fill it, so you avoid establishment of colonization by filling the dead space with inaccessible material as completely as is possible, and you eliminate sessile bacteria inside the remaining fragments using antimicrobial substances and concentrations as high and as consistent as possible. So the next thing is a single stage. So again, remove the implants and all the tissue, debride everything as much as is possible. You re-implant with cement, which is antibody loaded with gent or tobramycin usually. It's less popular, and you have massive problems in case of failure. So single stage exchange described with good results. Again, in the literature, some people have better results than others. Again, you need to know the organism. That's one of the most important things. It needs to be a less virulent organism for it to be appropriate for a single stage, and it has limited applications. really the two-stage is the mainstay of treatment for PJI, and principles are the same: remove, debride, put in a spacer, a static or dynamic spacer, 6 weeks of antibiotics, keep them off the antibiotics, monitor the bloods, revise again if you need to, and then definitively do your definitive revision. It's the gold standard for chronic PJIs. A two-stage with a 4 to 8 week course of IVs is standard, and it's recommended as initial treatment for acute PJI, specifically in immunocompromised hosts with resistant organisms. The overall success rate described in the literature is 67 to 91%. Again, multiple papers and systematic reviews. I'll highlight Murray's one in 2014, looking at 9 studies, none exactly comparable, different patient characteristics, but really, the results are pretty good, 85, 91%, and really a two-stage is the gold standard. This paper by Futo looked and found a success rate of 94%. And talking about spacers then, really 2 types, static versus articulating. Don't think it really makes a difference in hips. However, they're always loaded with either tobramycin or vancomycin or even gentamicin. And they're both pretty effective. They're bactericidal. They've very little cytotoxic effect and poor tissue penetration. Again, pretty good results. So for looking at prolonged oral antibiotic suppression therapy, this is really only indicated for patients who aren't fit for surgery and who maybe are at risk of amputation. And for that cohort of patient, it's a good option. The principles of antibiotics, you can summarize it as part of the 6 Ds. So diagnose your organism, know its sensitivities, discuss it with your colleagues in an MDT. You use the appropriate dose, and it's a common problem, I think, in that we put everyone on the same dose, but it's important to talk to your microbiologist and find out what the effective dose for a certain antibiotic and for a particular patient would be. The duration, we tend to put people on it for either too short or too long, but again, you really want to liaise closely with your resident microbiologist to figure out how best to manage these patients. And in most centres, you should really have a monthly MDT to discuss these patients. And then the delivery of antibiotics is one of the most important things, and actually one of the more exciting ways at the moment with developments. And really, when you're talking about local administration of these antibiotics, it's really one of the key things that we have in fighting PJIs. It allows a high local concentration of antibiotic with negligible systemic effects, whereas with standard IV antibiotics, we tend to have a low concentration where we need it, and with lots of systemic effects. There are various ways of delivering local antibiotic. You can directly inject it, you can put it in cement or in the spacers. Increasingly, I'm using calcium sulfate, and stimulant is something that we're using quite a lot of here in Ireland at the moment. It's bioabsorbable. You mix it on the table, you put in your antibiotics to it, and you just put it into your into your wound and close around it. This is a recent revision knee I did for an infection, and we took out all the implants, we put in the spacer, and you can see the stimulant beads there all around it. It's quite a dramatic x-ray, but it really does increase dramatically the amount of local antibiotic that you can administer to the area. It's important to discuss the prevention of infections and what we can do. So loads of things like chlorhexidine showers and wipes, removing hair, clipping and timing, hand washing and scrubs, alcohol scrubs. How we manage our comorbidities, optimize management of diabetes, malnutrition, morbid obesity is increasingly a problem, vitamin D, renal disease, smoking, all of these things need to be looked at preoperatively and optimized if possible. We look at various antibiotic prophylaxis. What we do, we use cefuroxime 3 doses, and there are various regimes used throughout the world. I think with teicoplanin, the results of infection tend to be higher. Cefuroxime or 3rd generation cephalosporins seem to have the best effect from the research that I've seen. And then surgeon influence. Surgical technique is important. Surgical time is very, very important as well, and that has been well documented. Again, you're looking at tissue penetration of the cephalosporins. You can see the cefuroxines and cefazolins tend to have the best efficacy in terms of tissue penetration. It's important to double glove. We can see that, 50 to 67% of gloves perforated during a total joint replacement. We change gloves multiple times during an operation. Again, skin preparation best using an alcohol-based solution, and that's what we try to use here as well. The exhaust suit thing is controversial. A lot of research at the moment saying that we don't need it. Some do, some don't. I don't think there's really any. It'd be interesting to know what you guys use in Egypt, but we kind of pretty much are split 50-50 here on whether we use them or not. And the same with laminar flow, and a lot of the research coming from New Zealand and the States is saying that actually you have a higher incidence of infection with laminar flow, but we do have it here, and we continue to use it and won't be changing it. So again, no conclusive effect or evidence of infection when looking at laminar flow. Lots of exciting new technologies being developed in the future for dealing with PJIs, including chitosan, bacteriophages, smart implants, enzymes, vaccines, antimicrobial peptides, UV light, hydrogels, surface coatings for the implants. That we lots of ongoing study for all of that stuff. So that's all I have to say. Thank you very much for listening, and thanks again for the invitation to speak this evening.
Thank you so much, Dr. Kelly, for this very interesting talk. I think it's a marvelous talk. I cannot compete with this talk at all. Thank you so much, sir. Mr. Kelly, you are with us?
I think maybe something in the connection. Yes.
Mr. Kelly? Yes, you are with us now.
I'm still here, yeah. Can you hear me?
There's a problem with the connection, sir.
Must be, yeah.
Thank you so much for this marvelous talk, sir.
Oh, thank you, and thank you again for the invitation.
Dr. Kamar is the moderator with you, sir. Dr. Kamar?
So Mr. Kelly, we have some questions, if you please.
Yep.
So the first question from Dr. Abdullah, he asking about can we apply the concept of MBCE on infection around implants of internal fixation also?
Yeah, I think so. And actually, if you look at the stimulan is the way of local delivery of antibiotics, and really we've only started using that here in the last year, and that has lots of exciting uses for those chronic osteomyelitis that you get in trauma and post-trauma. I think really that local delivery of antibiotics really is an exciting development, and all of the companies are coming out with new ways of delivering antibiotics locally, and for sure I think the applications in both trauma and for reconstruction and hip and knee replacements exciting, with lots and lots of potential, and I think the technology is improving all the time. So yeah, lots of applications, and yeah.
There is another question also from Dr. Abdullah asking, can we utilize the sonication technique while prosthesis retained and deal with the prosthetic joint infection at one stage, like we're doing one stage revision with using the sonic technique, the sonication technique?
Yeah, for sure. I think if your lab supports it, why not? It's not something we have available here, but it's certainly, again, it's still hard to beat your standard CRP and ESR. And I think if you look at the 2018 consensus meeting and the criteria, if you have some of the major and minor criteria with high inflammatory markers and maybe a positive aspirate of a joint, it's very hard to I think you can't really dismiss them. And if in your gut you feel that it's infected, and we often just know it, I think you just have to go ahead and revise it. So I think you can get carried away with various tests and imaging and everything, but I think ultimately if you suspect it's infected, it probably is, and you just need to get on and do a 2-stage revision, I think. Yeah.
There is another question. What the principles for selection of single or 2 stage for?
Again, I really only do 2 stages, and I think it's if you're going to a center, say, where you're doing just revision hips or just revision knees for PJIs, they're probably better placed to do a DARE procedure or a single stage. But I think, in most units here, we would just go ahead and do a 2-stage. I think the risks for reinfection or inadequate debridement with a single stage or a DARE is probably just too high. I think certainly my threshold for doing a 2-stage is pretty low. And it just means you can sleep a bit safer at night, I think, sounder at night. Yeah.
There's another question: is synovial fluid culture and sensitivity mandatory in all cases?
No, I don't think at all. I think it's very surgeon specific. But one thing that I would say is it's a good idea to have a monthly MDT and discuss these infected cases. And we in our kind of affiliated hospitals here in the west of Ireland, we would have that. We would talk about various infected cases that we would have and how best to manage them. And I don't think it's mandatory at all, but again, it's good to have the input of fellow orthopedic surgeons, but also your microbiology, interested microbiology consultants.
Yeah. I think this answer the last question is the significance of biduality in antibiotic administration and how to avoid toxicity of antibiotic. I think this is also, you mentioned this.
Yeah, I think that's where the local delivery again of antibiotics is really, really exciting, because over the last long time we give high dose IV antibiotics, and really the local effect of that is quite minimal, whilst it's having significant systemic effects on patients. Whereas if we can get in there to exactly where they're infected, deliver it locally using things like Stimulan or the spacer, and that's just a much more effective way of eliminating infection. And I think that's definitely the way management is going to change, and is already changing over the next few years.
Yeah. I have a question by myself. Do you prefer
I have a question. How have you learned to surf those waves already?
Yes,
You've only been with us here for a few months.
Regarding the revision of TKR, of total knee replacement,
yeah,
you prefer the static or the dynamic procedure?
I think dynamic is probably better with the knees. Yeah. I think it's just important for the surrounding soft tissues and muscle to have some movement, not excellent movement, but just to keep some movement going there. Yeah. But again, that's surgeon specific, and everyone. Yeah.
Yeah. Okay. And also the availability of the stuff.
Exactly.
Okay. So thank you. There is no
Great.
more.
Thank you again.
Thank you. Thank you.
Thank you so much, Dr. John Kelly, for joining us tonight with this very interesting talk. Thank you so much, sir.
Thank you.
Hoping to see you again and again with us.
Absolutely. And you're welcome to Sligo anytime.
Thank you so much.